as you mentioned, this is 45 years of the symposium. Today, we celebrated this year, and the symposium really started with 30 people in a room at the one of the hotels at the airport in San Antonio. And the goal for the founders, which was mostly Dr. Bill McGuire and Dr. Coltman, was to educate the community physicians about the latest in breast cancer research. They had a very strong program in San Antonio, and they knew all of the leaders of breast cancer in the whole world. And so they invited really very big names to come to San Antonio and just talk to the community oncologists. And from that, the symposium grew. In the early 2000s, we had around 3,000 attendees. And now we have around 10,000 attendees from 100 countries attending the symposium. The goal really is to understand breast cancer from prevention, early diagnosis, treatment, pathology, surgery, radiation oncology, medical oncology, and more importantly, basic research, translational research, and clinical research. So the strength of the symposium is that it includes all individuals that are involved in breast cancer research in one big room. The advocates were included in the symposium around 20 years after it started, because that's when advocacy started being very important. And so now we are very proud that we have advocates in all of our sessions, and they really are a big strength to the symposium. The studies that I think will change our practice start from looking at the breast cancer index in predicting benefit from ovarian function suppression in early stage breast cancer, showing that patients with a low breast cancer index have the benefit from ovarian suppression. There was also a wonderful study from Taiwan looking at the combination of a CDK4/6 inhibitor and endocrine therapy compared to combination chemotherapy in patients that had very aggressive metastatic breast cancer, showing that the CDK4/6 inhibitor and endocrine therapy outperformed chemotherapy. And so now I think for every patient with metastatic ER-positive breast cancer, we should consider the use of a CDK4/6 inhibitor. There was some wonderful data on racial differences in breast cancer, especially ER-positive disease, showing that African-American Black women have worse outcomes, but not necessarily because of adherence to therapy or anything else, but more because of the biology of the disease, which I think is really a first step in understanding why different racial groups do differently when diagnosed with breast cancer. We had Destiny Breast 02 presented and Destiny Breast 03 presented, and both of these trials showing an important and significant benefit of TDXD in patients with metastatic HER2-positive breast cancer. And so I think right now TDXD is being positioned as a second-line therapy in metastatic HER2-positive breast cancer. We had some updates from oral SERD drugs, including the Emerald trial, showing that elacestrant is superior to single-agent endocrine therapy, especially in patients that have tumors with ESR1 mutations. And this is a drug that is likely going to get approved by the FDA in the next few months. A wonderful trial, the Capitella trial, looking at capivasertib in patients with, again, ER-positive metastatic breast cancer, showing a benefit of capivasertib compared to standard of care endocrine therapy. And I would assume, based on this trial, the FDA will approve capivasertib as a treatment option. And we had another trial, which I think is extremely important, the positive trial, looking at women with ER-positive breast cancer who, after their diagnosis and after they were on endocrine therapy for anywhere between 18 to 30 months, they wanted to have children. And so they discontinued endocrine therapy, had children, and then restarted endocrine therapy 2 years later. And that trial showed that those women had similar outcomes to women that did not discontinue endocrine therapy. And this is extremely important for our young breast cancer patients that are on endocrine therapy, suggesting that if they want to have children and they want to discontinue endocrine therapy, it's okay to do so. So this year, we presented the 12-year data. Joe Sperano looked at the updated analysis and showed similar outcomes to previous years, in the sense that we know that chemotherapy did not seem to benefit patients with the intermediate Oncotype score. But he went into a little more detailed analysis based on whether women were premenopausal or postmenopausal and how old they were. And what he was able to show was that in women under the age of 40, chemotherapy did not seem to benefit them if they had an Oncotype score of 11 to 25. Women between the age of 41 and 50 did have a benefit as long as they were premenopausal. And then women over the age of 50 that were, or 45 to 50 that were postmenopausal did not benefit. And so to me, the take-home messages are that chemotherapy may help younger women because it makes them postmenopausal, but it seems to really work in a certain patient population that is between the age of 41 and 45. And in that patient population, we should consider giving chemotherapy. Emerald was a phase 3 clinical trial in women with metastatic ER-positive breast cancer. Women had been on a CDK4/6 inhibitor previously, and then their cancer had progressed, and they were randomized to either receive elacestrant, which is an oral SERD, or standard of care endocrine therapy, which was either fulvestrant or an aromatase inhibitor. The trial was presented last year, showing an improvement in median progression-free survival with elacestrant compared to endocrine therapy in all women and in women whose tumors had ESR1 mutations. But this year we looked at the prior therapy of CDK4/6 inhibitor and tried to look at outcomes depending on how long that prior therapy had lasted for. And we showed that in women where the CDK4/6 inhibitor had lasted for at least 12 months, those women had a much more clinically meaningful improvement in outcomes with elacestrant compared to standard of care endocrine therapy, especially in those tumors that were ESR1 mutated. So in women who had been on a CDK4/6 inhibitor for more than 12 months, that their tumors were ESR1 mutated, median progression-free survival in elacestrant was 8.6 months, whereas the median progression-free survival on single-agent endocrine therapy was only 2 months. So the FDA is evaluating the drug, and we'll see whether it gets approved or not. But based on this data, I think there is a patient population, especially with ESR1 mutations, and especially an endocrine-sensitive patient population, that would get a significant benefit from elacestrant.